But in a lot of instances, the patient does need to see a clinical officer or a health professional face-to-face. So it's not valuable in all situations, but it can be. And in some instances, the patient may choose not to see a physician through telemedicine. So it's new technology, it's intrusive, so the community has to get used to the technology, but it has many benefits if we can get people into care. Just don't want to go through all the names, but just want to thank those who have really helped us to implement this program. It's truly been a collaboration, not only with the district level hospitals, and some of the clinical directors are here with us, the superintendents, we really appreciate them being here, but it's been a collaboration within the community, and you can view these slides, and we want to thank those folks. And quickly, I just want to review what we talked about with the 4% no-show rate. In an underserved clinic, the way you look at these numbers, you can basically, in most underserved clinics, you can have as high as a 35% no-show rate because of the barriers of patients coming to a clinic. For telemedicine, you can run as high as 20%. The way you compare it is look at the no-show rate for a normal visit within the clinic, and from the 4 that we've been in, because there was no telemedicine previously. And what we're trying to say is, can we reduce that no-show rate through telemedicine? So 10% was a barrier that we set, as Dr. Milale talked about, but 4% is real successful rate as we see it, and that took a lot of work from our team, calling the patient ahead of time and making sure transportation was provided in certain cases. So I will leave it there, and thank you so much for the time.
Dr. Mark, just take a seat, okay, because we'll have a question and answer session. And probably Dr. Male will need to come back so that she can answer a few more questions on telehealth together with Dr. Mark. And I'll ask IHM to come and say something about their products and what they are selling. And I think there was a question on regulations of telemedicine, and that question was supposed to be answered by HPCZ. We will answer it. Thank you very much.
Thank you, Director of Events. We are not selling, but we've got products to showcase. So good morning, ladies and gentlemen, all protocols observed. My name is Kelvin Sikwibele. I'm the co-founder for the Institute for Health Measurement, Southern Africa. We are called IHM in short. We are currently the health informatics partner. Thank you. So we're currently the health informatics partner for the PEPFAR program. We are funded by the Centers for Disease Control to support the Ministry of Health to strengthen digital health. It's a 5-year award, and so I'll just show you what we are doing. And so we're really proud to be associated with the ZMA, and you see the relevance of what we're doing. Next slide, please. So quickly, next slide. Thank you. So quickly, what we're doing in the country is really 3 things. We are supporting the digital health agenda by putting in place and strengthening some of the current health information systems. And then we're really trying to take us forward to participate effectively in the 4th industrial revolution around data. And so one of those things that we're doing is we've built a data pipeline for the health sector. And then lastly, a data warehouse. Let me just go into each one of those quickly. Next slide. So in terms of health informatics, really, I'm looking at colleagues that are gathered here. You know SmartCare. It's a system that was designed primarily to help with HIV around about 2005, and it has grown over the years. It's gone through a number of hands, and now it is our turn to be at the helm of changing that. And so our approach really is to now move these systems from being data collection systems, but to systems that support the work that you do as clinicians. making sure that we see the benefits of technology in 3 areas. 1, to reduce the burden of data collection. 2, to improve patient-provider interactions. And then 3, because of technology, to begin to experience and demonstrably achieve better health outcomes. And so what we're doing at the facility level is to work with you to redesign the way these systems are being implemented so that then you can have that benefit. But also one of the things we've recognized is that the ICT infrastructure is not really optimal, and we're trying to change that. And so the way we are now developing and deploying these systems, we are using centralized architecture. Previously, when you have a change in the system, you had to go around the facilities of the country to do it, but now we're doing it at a central place. Overnight, you can see the kinds of changes that you need in a system, such as smart care. We're happy to announce that we now have an ITSM help desk for these systems. We've worked with facilities. This is something that we've published, and we keep advertising so that then people that experience problems in the facilities can then get the kind of help that you have. With the work that we've done on Smart Care, for example, we've reduced data latency now to 24 hours for Smart Care Plus. So in other words, when healthcare workers input data, the following day we have that data and you should be able to access it. We're in the process of rolling out Smart Care Plus in all health facilities to replace Smart Care Legacy, which has a data latency of 30 days. And then we've made the 2 systems, DHIS2 and Smart Care, interoperable. Next slide. And perhaps more interesting really is this whole discussion around data. I've always argued that the health sector has the most data in this country than any other sector. The financial sector always argues with me to say they've got more data, but I always tell them to say in the finance sector, it's only 2 things you do. You deposit or you withdraw. Now in the health sector, you start with registry. There's vitals, there's consultation, there's labs, there's pharmacy, there's specialist services. You can't beat that. On a daily basis, for over 3,000 health facilities, compared to less than 100 branches in the country, no, they can't compare. So now, with that, we recognize the responsibility that we have to ensure that then this data is available for practitioners like yourselves to better understand what is happening in your facilities. So what we've done is to build literally a data pipeline for all these systems. Why is this important? First of all, the quantities that I've mentioned, but more importantly, data quality. So what we've done in the past is really to describe the quality of data by speaking about over-reporting or under-reporting. But what we've done now is we've introduced tools like talent data management tools that literally open the box on the database to see the data as it is, as it moves from the facilities to the central repository. And we can actually tell you what the defects are with that data so that then you can fix it. So for the first time, we're now bringing the whole issue of data quality into your hands to fix things, not to just describe it. And so what we've done now is to set what we call a data quality rate, which is Sigma 4, for those of you who are inclined to these kinds of things. Sigma 4 is a data quality rate which is at 98.4, which is acceptable in the health sector. So that's the target that we've set. We want to move the quality of health data to that level. When we took over this project, one of the things we used to hear was that smart care data is not very good data, we can't work with it. So now we are trying to show you that we are putting in place mechanisms that will give you the confidence to work with routine data. For those of you who are researchers, this is a conference. One of the beautiful things about routine data is that it is a precursor of your research studies. It helps you to begin to see what is happening. And so if we can assure you the quality of data through this automated process, you'll be in a better place then to be able to put together research questions that then can allow you to put together your protocols that can get funded. Last slide. Last slide. So over and above just moving that data, one of the challenges with the systems that we have in the health facilities is people being able to access data. So we've developed a data warehouse for the Ministry of Health, the first of its kind in the country, and I can tell you now, the first of its kind we've heard people talk about repository in other parts of Africa, but none of them has put together a data warehouse as we have done. And in fact, our plans are that by the end of September, we should transition from a data warehouse to a data lake. I think for me, if there's anything I can give you in my presentation about what we're doing that really should excite you is exactly this. So now as a Ministry of Health, you have one single place, a source of truth, for all the facility-based systems to start with, SmartCare, DISA, ELMIS, and then we can even add, we've added the Human Resource Information System. We're working with colleagues in the Ministry of Health to add even financial and planning data in terms of Navision and Logistimo. So for those of you who are researchers, if you want to then to understand, potentially asking yourself, what is making Zambians sick? What is killing Zambians? So as an exploratory question, and as a place where you can start with, we've got the data warehouse. It's been set up. We're working closely with the ICT department in the Ministry of Health. You'll be seeing soon efforts to advertise and get all of you on board to be able to use this data. So in a nutshell, if you think about it, this is what we're doing. We're strengthening the ICT infrastructure in the country. We are fixing and putting in place the data pipelines, and then we're making your data available. So bringing it back to this conference now, whose theme is around digital health, with the sub-themes around non-communicable diseases, climate change, telemedicine, and antimicrobial resistance. So for those of you who are in NCDs, and you want to understand what the prevalence of those are, so that then you can go ahead with your research questions, you've got the data warehouse. Climate change is changing the way diseases are emerging. Previously, Lusaka was regarded as a low malaria zone, but with these kinds of things, we'll see what will happen. We saw what happened with COVID, the way it was transmitted rapidly around the world. So this is beginning to give you access to the data that you need to be able to do the work that you want. So at the policy level, if we want to understand what is killing Zambians, we now have the data. At the operational or strategic level, we now have the data that can help us see how we improve or change service delivery. And at the facility level, if you want to understand the impact that you're making in terms of your client volumes and the numbers of ailments or conditions that you're dealing with, we now have the data. Colleagues, we are the Institute for Health Measurement. We are proud to be associated with the Ministry of Health. We thank our sponsors, PEPFAR, for the work that we do, and we hope to interact with you during this conference. There's a booth just outside the door. You're more than welcome. Thank you. Thank you.
Thank you very much. There's a lot happening. Could I ask Glenn Mack to also come and say something about what they do and their products? And then we'll go into a question and answer session that will be taken by Dr. Paul Ravi. Glenn Mack? All right, so we move straight to the question and answer session. Dr. Paul Ravi, please.
Thanks, Prof. So we will take up questions for Dr. Mack and the presenter earlier. So there's a hand there. We can start with you, please.
Thank you, Kevin Zimba. I would like to ask a question to IHM. I'll start first by, it may be a joke, but it's something that's quite real. I always say the people who develop SmartCare, if they worked for a bank, would have problems, because every time you have a new patch of SmartCare, you've either lost patients or you've gained patients. So I say if they develop banking apps, you'd either have more money in your bank or you've lost money in the account. So I think you've made great progress, but I think we need to address those gaps. I think our developers need to be a bit tactful, because every now and then you have a new patch, you either lose patients or you have some kind of data that is a bit difficult to get. Coming from the TB front, we have challenges in collecting data from SmartCare that is used. So the question I would like to ask is, who owns this data, and how can this data be made easy to the TB program to access it from SmartCare, because it's a big challenge that we do have. My third question, or that was the first. Second question is, Do we have a smart care implementation plan or a strategy? When do we envision Zambia to be at least 90% of our facilities smart care, fully smart care implemented or having smart care run? The reason I ask this is that we have several facilities in the country that have smart care. Wing of that facility has smart care. For instance, in the TB space, if I'm trying to find the presumptive patients that came through, I need to have smart care in the OPD. I need to have smart care in the inpatient. I need to have smart care in the wards, in the lab. I like just having smart care in the TB clinic because I'm just creating another data reporting tool and maintaining the old paperwork. So in the end, it becomes ineffective to keep using the smart care, hence we have the challenges. Thank you.
Excuse me? In front, Professor Bimba.
Thank you so much. My question is to IHM. Again, my name's Godfrey Biemba. I'm the Director and CEO for the National Health Research Authority. This was a very interesting presentation by IHM, and I would like to visit your booth later on. But my question is whether you are able to develop real-time drug supply monitoring system. I know you referred to ELMIS, but I had asked this question at some fora, and I was told there's no system for real-time monitoring of drug supply in the country. So the question is, what will it take? Are you able to do that? Because this is very important. As you all know, we have had challenges in knowing what our drug supply situation is at any one time. Thank you.
Thank you. There's another hand there.
Thank you. Malilwe Muhuma, medical doctor and software developer. My question is to Morehouse. Very interesting presentation on around telemedicine. And having seen some of these equipment firsthand at Misisi and Kuku, I know you talked about improving retention and viral load coverage. So I just wanted you to shed more light on that, because having been on the ground, we really haven't seen an impact, especially when it comes to telemedicine and improving viral load coverage. So I just wanted a bit more detail on that particular front. Thank you.
Okay, as there are no more hands, so maybe, yeah. Okay, that's it. Sure.
So I'd like to to make a response to the question about stock, real-time stock status. If it's the appropriate time to do so. Can I go ahead? Or maybe you are still asking questions. I wanted to assist the IHM presentation on real-time stock visibility.
Yeah, question first.
Margaret Casaro again. I have a question for Morehouse. School of Medicine. In terms of the kit that you've just shown, the one that goes to the patient and that it can be taken to their house, thinking about the remote areas of Zambia or other settings that you may use this, what kind of power systems do you use? How long will that last? Is this something that maybe can be powered through solar systems? Thank you.
Okay, so maybe we will ask the presenters to answer these questions first. We can go with Dr. Mack and Dr. Mwale first. Yeah. Or you can come in, yeah, please.
So thank you for the questions. So the efficiency of patches, I think, to start with. Can we see the kind of efficiencies? So yes, we can, and we are. As I mentioned, we've changed the architecture of smart care. Right now, we have two versions of smart care. There's the legacy system that we're trying to replace, and the newer system, which is Smart Care Plus. Now, you mentioned to say each time there's a patch, smart care, you lose numbers in facilities. Maybe I should use this opportunity to clarify. So whenever we introduce electronic systems, like the one that we're introducing now, Smart Care Plus, they are robust. They force you to do what you need to do, unlike paper where you can go back and make a change and get away with it. Those of you who've worked with electronic systems that have got strong auditing trails, you will agree with me to say you can't just make a change. So what happens with smart care, and what that question was referring to primarily is in the area of HIV, where they're quite particular about their numbers in terms of reach. So we work with you as clinicians to understand how you enroll a patient. What is it that says you've enrolled a patient? You tell us. Then we enforce that logic. Now, when we replace the old system with the new system, the old system was porous. The new system tightens the logic because the old system would count a number that a patient that was not supposed to be counted. So when we introduce the new system, it cleans up, and that's why the numbers drop. And so if you look at your research, actually, whenever electronic health records have been introduced anywhere in the world, just look at that research. You will see what they do is they improve the quality of data. They also improve your data holdings, specifically cleaning out, and numbers reduce. So on paper, we can play with those numbers and have them as much as we want, but electronically, when you try to, we will see that you were tampering with the systems, and therefore you've worked with them. I mean, you've done what you needed to do, and then we'll hold you accountable. So whenever we do that, we strengthen the logic of calculations, and it cleans out. That's why some numbers drop. We've had cases where part of the reason why the numbers drop out is simply because files were not updated. And again, it's a tight system. So if your file is not updated, it will drop it. And we've worked with facilities. Most recently, we're working with facilities to clean up those files that were behind. And so we've seen an improvement in the numbers as a result. The second one is about TB. To say you work in the TB program. As far as I know, we are actually working with, we've worked with the TB program to get your new requirements to strengthen the TB module. So please just be on the lookout in terms of that new module that will be announced. The other question was around scale-up plans. Yes, Smart Care is currently in 1,600 facilities. We're in 3,000 facilities. When we took over this project, one of the things we made sure we made known was that Smart Care needed to be in all health facilities, not even 90%. And so I'm happy to announce, to say we are working closely, not just with PEPFAR, but with government and other development agencies. And so from where we are, our projection that we should be in the 90 that you've mentioned, in the 90% of those facilities by the end of 2024. So it's looking good. And again, you can imagine what that will do in terms of giving us the kind of data that we need. My colleague, Jeremy from JSH, John Snow Health Group, we work together with them. They manage the electronic logistics management information system for drugs. But maybe before he comes, what we're doing is we're collaborating to answer that question because we want to understand what's really happening, where the leakages are happening. So ZAMSA is able to show us to say, this is the data that shows you distribution. ELMI speaks it from ZAMSA in terms of the drug catalog and is able to show us where these drugs are in the facilities. Then we come in to look at dispensation data. Because from our side, a physician is supposed to say to us, in this month, I had 30 cases of malaria that I looked at and dispensed, or prescribed rather, sorry, not dispensed, prescribed. Jeremy is supposed to tell me to say, the pharmacy has 100 doses of Coartem, and therefore we should expect 70 based on the 30. And we are doing that now, and it's interesting what we are seeing, actually, because we are finding those discrepancies. So with our collaborative effort, we are now beginning to plot and to show where those leakages are happening, whether they're happening at ZAMSA, whether they're happening at the distribution centers, whether they're happening in the facilities. So we're working on putting together dashboards, actually, that will be used by the Ministry of Health leadership to basically answer exactly those questions. Now, is it real time? No, it's not real time. It is real time to the extent that it is up to 24 hours, I think. Yeah, it's as recent as 24 hours. So when the facility closes at the end of the day, we have that data, where the systems are present. And so what we've done is we are making smart care and LMIs interoperable, so that now when a clinician prescribes in smart care, the pharmacist can pick up that prescription and be able to dispense, and the stock status changes in LMIs in that regard. And again, going back to the issue of strong audit trails, because now we can know which physician prescribed and prescribed how many doses. Now we can know. Now we know, we've got the data, Jeremy, of pharmacists who dispensed what drugs. What has been a challenge is to marry these two, the prescription data and the dispensation data, so that then we can see where those leakages are happening, so that then we can address this matter. But maybe Jeremy wanted to add quickly.
Yeah, so just to add quickly, so the point of real time is it's a long journey. We came from when JSI then started in 2006, the logistics system, up to 2014, papers were flying from facilities up to, and were entered in ZAMSA, then medical stores manually. So we've been coming a long way, from a long distance, and we are at a point where we have transactional data at facility level. You can see real time at facility, within a facility you can see what's happening. And we were training doctors yesterday and the previous day. We were training some few doctors who will be working with other doctors to just share the ideas that at a facility level, you can see what's happening anytime. At a district and higher levels, because of the challenges we have with connectivity and things like that, we still are struggling. So we, like Kelvin had mentioned, we have, the system has been programmed to send data on a 24-hour basis. We're calling it near real time because of the infrastructure challenges that we have. So facilities can submit reports from facility edition to central edition, which is accessible everywhere. And tomorrow we'll have a brief, we have a presentation tomorrow, we'll show you the ELMIS. If there's a facility edition which is at the facility and a central edition where you can see that data. However, you can only see it after, like at 15 hours, that's when it transmits. Now there's a problem with that as well. That data is not coming so regularly because not so many facilities are online 24/7, issues of infrastructure as well. So the softwares are ready, but we still have a long way to go before we can probably make that real-time visibility a reality.
Thank you for the questions. I'll start with the power source